Okay, we are going to begin. Welcome everyone to our third webinar of the series for the National Hispanic Hepatitis Awareness Day 2018. Before we start the webinar, we have some housekeeping rules. I have muted everyone online so we don't get interrupted by the background noise. So if you have questions or comments during the presentation, share them with us in the chat function of the platform, so we can answer or address them during the questions and answers section at the end of the webinar. Also, this meeting is being recorded. Again, welcome everyone, and thank you for joining us this afternoon for our webinar about the updated National Viral Hepatitis Action Plan 2017-2020. My name is Luis Mares, and I am the Director of the Community Mobilization Programs at the Latino Commission on AIDS in New York City. Our presenter today is my friend Lisette Marrero. Lisette is the Regional Resource Consultant for the Regional Resource Network program supporting of the U.S. Department of Health and Human Services in the Office of the Assistant Secretary for Health to create a coordinated effort in the federal response to HIV and viral hepatitis, and work on a multi-tier level to provide technical assistance, training, education, outreach, and support within Region 2, which consists of New York, New Jersey, Puerto Rico, and the United States Virgin Islands. Lisette began her career as the School Health Project Associate at SECUS, the Sexuality Information and Education Council of the United States, focusing on sexual health of youth and the advocacy of national comprehensive sexuality education around the United States. From 2001 until 2016, Lisette served as Deputy Director and Administrator at the Adolescent AIDS Program at the Children's Hospital at Montefiore Medical Center in the Bronx, in New York, providing comprehensive medical and mental health programs to HIV-infected and LGBTQ youth. Lisette received her bachelor's degree in psychology from the City College of New York and a master's of social work from the Silverman School of Social Work at Hunter College. Thank you, Lisette, very much for being with us today. The floor is all yours.
Thank you, Luis. I am excited and privileged, as always, to collaborate with you and the Latino Commission on AIDS. And I welcome everyone who is participating today and has logged on to today's webinar. So today I will be discussing and providing for you an updated National Viral Hepatitis Action Plan from 2017 to 2020. Having trouble advancing? Thank you. Viral hepatitis is the leading cause of liver cancer in the United States. Approximately 1/3 of people living with HIV are co-infected with hepatitis C or hepatitis B. Hepatitis C kills more Americans than all other reportable infectious diseases combined. There is an estimated 3.5 million people living with hepatitis B, which is the most common type of viral hepatitis. There is also an estimated 850,000 people living with hepatitis B, and 1 in 4 people who are chronically infected with hepatitis B will die prematurely. Latinos are 60% more likely to die from viral hepatitis than their white counterparts. Despite having lower rates of hepatitis C, Latinos within the baby boomer cohort are 6 times more likely to be infected with the hepatitis C virus and were 50% more likely to die from hepatitis C in 2015. The reason is that many Latinos start off with a genetic disadvantage called fatty liver, which means that they have a high likelihood of having non-alcoholic fatty liver. A fatty liver occurs when you take in more fat and calories than your liver can process. So having a diet that is high in fat and calories is obviously problematic, but also can be culturally difficult. And, I can speak for myself as a Puerto Riqueña that I was raised eating lots of fatty foods like chuleta, pernil, and cuchifrito, as opposed to eating things that were or are a lot more healthy like leafy greens and baked foods. And even I had a lack of understanding that we are truly we are truly what we eat, and that foods are metabolized differently depending on the person. So other risk factors include those born between 1946 and 1964, which are the baby boomers, and individuals who had a medical procedure that included blood transfusions and had received blood products or organ donations prior to 1992, before there was any widespread testing of the blood supply. Other populations at high risk for viral hepatitis and represent high rates of infection are men who have sex with men, homeless individuals, pregnant women, people in correctional facilities, people living with HIV, veterans, people who inject drugs, African Americans, and Alaska Natives, as well as Asian Pacific Islanders. As we have already discussed, viral hepatitis poses a serious threat to the health of millions of Americans. In 2011, the United States developed a coordinated national response to viral hepatitis in the release of the first action plan for the prevention, care, and treatment of viral hepatitis. Since that time, the federal and non-federal stakeholders' efforts have evolved and advanced in response to the growing threat of viral hepatitis. And despite the progress, viral hepatitis remains a serious threat, with the number of new hepatitis C infections rapidly increasing. Prior progress in reducing new hepatitis B virus infections has stalled, and hepatitis-related deaths have increased. The updated National Viral Action Plan 2017 to 2020 is a new phase in the fight against viral hepatitis in the United States. It is a national plan, not just a federal plan, and it recognizes that success cannot be achieved by federal action alone, and is intended to guide individuals and organizations from all sectors of society to strengthen our collective national response to hepatitis B and C infection. We now have the knowledge and tools to save lives and win the fight against viral hepatitis. The updated National Viral Hepatitis Action Plan for 2017 through 2020 uses this knowledge and these tools to outline 4 major goals. The first one is to prevent new viral hepatitis infections. The second one is to reduce deaths and improve the health of people living with viral hepatitis. The third is reduce viral hepatitis health disparities. And the fourth is to coordinate, monitor, and report on implementation of viral hepatitis activities. We can accomplish this by aligning goals and sharing strategies among key partners, engaging stakeholders across all sectors, leveraging important advances, confronting challenges, and prioritizing our efforts to reach the populations most impacted. Within each action plan goal, there are a number of strategies that were developed. And because of time restrictions, I will only highlight a few from each goal that I think are worth mentioning. So in Goal 1, under Prevent New Viral Hepatitis Infections, we are working to increase community awareness of viral hepatitis and decrease stigma and discrimination, eliminate mother-to-child transmission of hepatitis B and hepatitis C, ensure that people who inject drugs have access to viral hepatitis prevention services, and conduct research leading to new or improved viral hepatitis vaccines, diagnostic tests, and treatments, and the optimal use of existing tools to prevent, detect, and treat viral hepatitis. In Goal 2, under Reduce Deaths and Improve the Health of People Living with Viral Hepatitis, we are working to identify persons infected with viral hepatitis early in the course of their disease, improve viral hepatitis treatment among persons living with HIV and AIDS, ensure that people who inject drugs have access to viral hepatitis and evidence-based treatment services. And lastly, to expand access to and delivery of hepatitis prevention, care, and treatment services in correctional settings. In Goal 3, under Reduce Viral Hepatitis Health Disparities, we are working to decrease health disparities by partnering with and educating priority populations and their communities about viral hepatitis and the benefits of available prevention, care, and treatment. to improve access to care and the delivery of culturally competent and linguistically appropriate viral hepatitis prevention and care services, and advance basic clinical, translational, and implementation research to improve understanding of and response to viral hepatitis health disparities. And then in Goal 4, under Coordinate, Monitor, and Report on implementation of viral hepatitis activities, we are working to increase coordination of viral hepatitis programs across the federal government and among federal agencies, state, territorial, tribal, and local governments, as well as non-governmental stakeholders from all sectors of society. And lastly, regularly report on progress towards achieving the goals of the National Viral Hepatitis Action Plan. The National Viral Hepatitis Action Plan includes 17 indicators of progress selected to aid in monitoring and measuring the results of action plan implementation and to support accountability and transparency. Again, for the purpose of time, I will highlight only a few. So in Goal 1, under Prevent New Viral Hepatitis Infections, we are looking to achieve a decrease in the number of new hepatitis B and C infections by 60%. In Goal 2, under Reduce Deaths and Improve the Health of People Living with Viral Hepatitis, we are looking to increase the percentage of persons aware of their hepatitis B and C infection by 66%. In Goal 3, under Reduce Viral Hepatitis Health Disparities, we are looking to achieve a decrease in the number of new hepatitis B infections among individuals 20 to 49 years of age by at least 60%, and reduce the number of hepatitis C deaths among individuals 55 to 74 years of age by at least 25%. Goal 4, which you don't see on the screen, which is to coordinate, monitor, and report on the implementation of viral hepatitis activities, does not lend itself currently to qualitative and quantitative indicators, so other methods to assess progress for this goal will be employed. The action plan seeks to leverage important advances and opportunities as we work to achieve its goals. For example, 1, screening recommendations. To ensure that accurate hepatitis B and C screening tests exist and are covered by most health insurance plans without extra charge to the consumer. 2, to expand access to health coverage, which is to ensure that hepatitis A and B virus vaccination and hepatitis B and C screening services are covered preventive services, creating more opportunities for Americans to receive these critical services without cost sharing. And C, developments in hepatitis C cure. The approval of highly effective all-oral therapies has the potential to cure more than 90% of chronic HCV infections, or 3.15 million of the 3.5 million people in the United States with chronic infection. However, only 54% of people are currently aware of their infection, and a study published in 2014 estimated that only 9% of infected people have been treated with HCV. So therefore, it will take sustained and coordinated efforts to realize the full potential of the new HCV treatment. 4 is integration of public health and clinical care services. Studies have shown that integrating and including viral hepatitis prevention and care services with other physical health, mental health, and social services can effectively prevent infection or identity and link individuals with viral hepatitis into care. Partnerships between organizations providing public health services, clinical care, substance use disorder services, mental health care, case management, and syringe and other risk reduction services to populations at risk can help reach more individuals at risk for or living with chronic viral hepatitis. And then lastly, 5, developments in syringe service programs. In 2015, in response to the growing opioid epidemic and the related increase in transmission of viral hepatitis and HIV, Congress allowed use of federal funds to support syringe service programs under certain circumstances. For example, the government will not fund syringes themselves, but will fund wraparound services and staff time. And some areas need to demonstrate risk for outbreaks of HIV and HCV to be eligible for funding. These programs have been shown to reduce viral hepatitis risk and are an effective component of a comprehensive integrated infectious disease prevention strategy. The action plan also seeks to address a number of challenges that must be confronted as we work to improve our national response to viral hepatitis. For example, limited data is one of the most critical gaps in our response to viral hepatitis. Because of limited data, the incidence, prevalence, and geographic distribution of viral hepatitis can only be estimated. Consequently, outbreaks may remain undetected, and health officials may not realize the scope of the problem or have the information they need to appropriately prioritize resources to address it. Low levels of viral hepatitis awareness among healthcare providers lead to low rates of vaccination and missed opportunities for testing and diagnosis, linkage to care, as well as treatment. Low public health awareness of hepatitis B and hepatitis C and corresponding low levels of perceived risk lead to continued stigma and discrimination, missed opportunities for prevention, testing, diagnosis, linkage to care and treatment, as well as ongoing transmission. Limited public health and health system response and the insufficient investment in health systems to address viral hepatitis has led to fragmented and uncoordinated viral hepatitis services in public health and clinical settings. The high cost of viral hepatitis treatment can have an effect of limiting access, leaving many people chronically infected and at risk for severe liver disease, liver cancer, and unfortunately death. And lastly, stigma and discrimination may cause people to avoid testing and treatment and fear of disclosure of their status to friends, family members, and colleagues. This can lead to worsening health outcomes. People with viral hepatitis are protected from discrimination under several federal laws, including the Americans with Disabilities Act and the Rehabilitation Act. From 2011 through 2014, there was a 250% increase in reported new HCV infections due to the increased use of opioids. There is a correlation between drug overdose and hepatitis C infection. The rate of opioid injection use, especially injection of prescription opioid pain relievers, as well as heroin, and acute HIV hepatitis infections increased most dramatically from 2004 to 2014 in younger Americans. You will see that among 18 to 29-year-olds, there was a 400% increase in acute hepatitis C infection. There was an 817% increase in admissions for injections of prescription opioids and a 622% increase in admissions for heroin injections. You will also see that among 30 to 39-year-olds, there was a 325% increase in acute hepatitis C. There was a 169% increase in admissions for injection of prescription opioids and an 83% increase in admissions for heroin injection. There was also a sharp increase among whites and among women. And you don't see this in this slide, but according to the CDC, there has been an increase in the rate of new hepatitis B infections since 2014, which is likely due to injection drug use. This current slide shows the opioid epidemic by numbers. In 2016, 116 people died every day from opioid-related drug overdoses. In the same year, 11.5 million people misused prescription opioids. Over 42,000 people died from overdosing an opioid. 2.1 million people had an opioid use disorder. Almost 1 million people used heroin, and 170,000 people used heroin for the first time in 2016. That was a pretty alarming statistic for me when I first read it. And, you know, we have to think about some of the social implications as to why people are using opioids as well as moving to injection drug use. 2.1 million people misused prescription opioids for the first time. Over 17,000 deaths were attributed to overdosing on commonly prescribed opioids. Over 19,000 deaths were attributed to overdosing on synthetic opioids other than methadone. Over 15,000 deaths were attributed to overdosing on heroin. And all of this costing about $504 billion to our economy. So injection drug use associated with HIV is increasing after a 10-year decline. 220 counties have been identified as vulnerable to outbreaks of HIV and hepatitis C. 39 states and counties have met criteria for using federal funds to support comprehensive syringe service programs. And places like Scott County, Indiana, is recovering from the largest well-documented HIV outbreak among injection drug users, with 190 cases of HIV infection in 2015. What was astounding about this case was that historically, fewer than 5 cases of HIV infection have been reported annually in this county. And if any of you are really interested in learning more about this case, because it's pretty fascinating to read about everything that happened in Indiana at that point, you could look at the May 1st, 2015 issue of the MMWR, which focuses on the community outbreak of HIV infection linked to injection drug use by the use of opioids. And that MMWR means Morbidity and Mortality Weekly Report. So in 2017, HHS, Health and Human Services, declared a public health emergency and announced a 5-point strategy to combat the opioid crisis. So the first point, or the first strategy, is to provide better addiction prevention treatment and recovery services. There was $485 million in grants that became available for evidence-based prevention and treatment activities funded by the 21st Century Cures Act and was distributed through the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The second strategy is to provide better overdose reversal drugs. As part of the state-based grants, there is a push to promote the use of life-saving drugs like Narcan and explore new drugs that could have life-saving effects. Strategies 3 and 4 combined, which provide better health surveillance data and research to examine what new kinds of treatments are available, both pharmaceutical and otherwise. Also to really learn how we can help to fight and combat opioids across the nation, and to also look at, are there new kinds of painkillers that are less addictive and safer, or can we develop a vaccine for opioid addiction? And then number 5 is provide better pain management treatment, therefore revisiting and rethinking the revolution in pain management that has taken place over the past several decades, which has done a great deal of good, but has also had devastating and unintentional consequences, unfortunately, for millions of Americans. There is also a call to action for every sector to get involved in ending AIDS, viral hepatitis, and the opioid epidemic. So what can we do? We can familiarize ourselves with the National HIV/AIDS Strategy to focus efforts on reducing new infections, which includes information about routine HIV testing, pre-exposure prophylaxis, and the dissemination of condoms. Increase access to care for people living with HIV that includes treatment and viral suppression, and promotion of U equals U, undetectable equals untransmittable. Reducing HIV-related disparities and health equities that include the elimination of stigma and achieving a more coordinated national response to the epidemic that includes monitoring progress towards ending the epidemic. 2, we can focus on also ending the opioid epidemic, which will require an increase in Narcan distribution for first responders, family and friends, and other community members in affected areas. And they are providing tons of training. I know in the New York area, I'm sure they're providing trainings in other parts of the United States to really get people aware of what's happening with the opioid crisis, but also trying to really reverse any opioids that are happening in those states. Also to increase availability of and access to treatment services, including mental health services and medication-assisted treatment for opioid use disorder, coupled with behavioral health, which is very, very important, and the support of harm reduction programs, including those offering screening for HIV, hepatitis B and C, in combination with referral to treatment. And lastly, everyone has a role to play in the national response to viral hepatitis and in the fight against related stigma and discrimination. Organizations and individuals from around the country must step up to do their part and to make the action plan a reality. HHS Office of HIV/AIDS and Infectious Disease Policy, also known as NHHAD, recently announced the launch of the Partner Planning Guide for the National Viral Hepatitis Action Plan 2017 to 2020. This strategic planning resource is designed for the use of individuals, groups, and organizations that are conducting strategic programs and providing services to prevent diagnosis and treat hepatitis B and/or hepatitis C. The guide can help you, your agency, or organization to access local needs, strengths, and existing activities, as well as plan new actions that align with the action plan and contribute towards reaching our national viral hepatitis goals. It can be used in conjunction with existing strategic plans to identify shared priorities and goals, as well as opportunities for alignment and leveraging of capacities and resources to improve the programs that serve individuals and communities in need. Next slide, please. This guide will provide the framework for knowing your epidemiology, seeking epidemiological and qualitative data on the scope of the epidemic in your defined areas, such as the rate of new infections, hepatitis, mortality data, demographics of the epidemic, and vaccination rates. It would also help in knowing your capacity, reviewing the mission of your organization or partnership for alignment with the identified area or areas of need, assessing organizational and/or partnership capacity, and availability to address the identified areas of need. Also, it will help with setting your goals, reviewing the goals of the action plan, and selecting the goals of the best aligned strategy with the areas of need identified in step 1 and the mission of the organization or stakeholder group. It will also help in choosing the best strategies, identifying the strategies for the action plan that addresses the identified areas of need. It would also help in engaging stakeholders, using the questions in the planning guide to frame a discussion between all involved stakeholders. And lastly, it would help with planning your actions. At the end of the planning guide, there are blank action planning sheets to help you organize the strategies and actions. Here are a list of resources for you to look at your leisure. These are links to the National Viral Hepatitis Action Plan to 2020, a direct link to the opioid section of the HHS website, and the link to the National HIV/AIDS Strategy to 2020. I'd like to end my presentation with a quote from Frida Kahlo. I must fight with all of my strength so that the little positive things that my health allows me to do might be pointed towards helping the revolution, the only real reason for living. So with that, I thank you all for your time this afternoon to listen to today's important presentation. And here's my contact information. And I believe we are now open for discussion and questions.
That is right. Thank you, Lisa, very much for this information.
You're welcome.
Very, very important to know. So now the floor is open for any questions or comments that you may have to Lisette. You can write your questions. There is a comment from Esther Megan. She says, thank you for having this webinar. It's very informative. And in her opinion, if the better pain treatment will indeed help to combat the crisis of the opioids. So anyone would like to make questions, just write it on the chat box.
Yeah, thank you, Esther, for your comment. And I agree with you that we need to do a lot of work and research on trying to figure out pain management and what does that look like and what does that mean for people and alternative ways. I mean, you know, you don't always have to treat pain with a pill. There's acupuncture. There are a lot of ways to deal with pain. There's physical therapy, but there are some studies out there right now looking at different things that we need to do in order to combat the opioid crisis. One of the things that I didn't mention in my presentation that I found really interesting is that there are certain places in the U.S., San Francisco is actually one of the cities that's actually implementing this, is testing kits for fentanyl. As most of you know, fentanyl is a synthetic drug that is put in heroin, and that is one of the major causes for overdose. And if we use a harm reduction approach and we are testing the drugs that are out in the community that can be done on a mobile van, that can we can be able hopefully one day to distribute that just like syringe exchange programs or giving clean needles, we can probably reduce dramatically and potentially eliminate some of the drug overdoses that are happening throughout our country.
Thank you. There is a question from Mark. Is there research developing on migration of residents from Puerto Rico to New York and Florida and the impact migratory travel can have on health needs, include care for hepatitis C?
You know, I'm not currently aware of any specific research that is happening currently on the migration of residents from Puerto Rico to New York and Florida and the impact on hepatitis C. In particular, I can definitely ask some of my colleagues and some of the experts in this area and get back to you, Mark, but I think it's an interesting question, and I think, you know, in terms of just all health disparities or health needs in general, not just hepatitis C, but HIV and other issues related to, you know, the travel of back and forth. I mean, you know, going from New York to Puerto Rico and Florida, we know that that's something that's happening daily, and how, you know, that impacts the lives of Latinos living on the mainland and on the island. So thank you for your question, and I wish I had more information to answer that question specifically, but I can definitely look into it, and I'm sure the commission can look into that as well, as they're doing tremendous work in both Puerto Rico and in Florida.
You're welcome, Mark. Anybody else have a question? Is there any similarity between the ending plan that exists for HIV with this hepatitis C plan, Lisa?
Yeah, I think there's definitely correlations because we know that, especially in terms of injection drug use, or we look at certain populations like men who have sex with men who have a higher risk of getting both HIV and hepatitis C, that it really is about raising major awareness, making sure everyone is either screened or tested for HIV and hepatitis C, and that to get them on life-saving treatment, right? So for HIV, as part of the plan for 2020 is to make sure that those who are HIV positive are linked to care and are getting on antiretroviral therapy so that they can become virally suppressed, right? And we know in terms of the U equals U campaign that if you are virally suppressed, if you are undetected, if you have a viral suppression a viral load that is undetectable, you will not transmit the virus of HIV. And in terms of hepatitis C, we want everyone to be screened, connected to care, and we want them on treatment. And we know that the new treatment for hepatitis C, which is a 12-week regimen to achieve viral suppression, has a 90% cure rate. So they are in line, and we are looking to eliminate both, and we know that we have the tools, the information, the strategies, and the treatment to achieve that, but we can't work in silos. And health centers, community health centers, community-based organizations, health departments and hospitals have to align, and we have to come together so that, we can make sure that we meet the goals by 2020. And I know New York is doing such a great job at really trying to reach that, but this is a national effort, and we can't forget, all of the territories and tribal nations because they are also equally affected. So what I would ask of all of you who are on today's call is to go back to your, directors and administrators and really look at your mission statements and say, do we have something that that really speaks to both HIV and viral hepatitis, and what, programs and funding do we have so that we can work along with, all of the programs that are working to eliminate HIV and viral hepatitis.
There's a question, Lisette Allen asks, do you have any info of how long it is taking to get people to diagnosis and then to treatment in private and public and safety settings?
Yeah, it really varies by treatment center. I mean, everyone has their own kind of treatment cascade. I think the best place to get this information, if you're looking for that, I don't know if you're in New York, Alan, but, the AIDS Institute has a lot of this information. What I will tell you is that what's limited is co-infection information, so that's hard. But I know I just went to a presentation by the New York City Department of Health, and they're really working really hard in their programs to try to get people in after diagnosis within 24 hours. And when I worked at Montefiore Medical Center, that was also our standard of care, that we wanted to get people into treatment within 24 hours of diagnosis, and trying to get them, on medications as soon as possible. So I wish I had a kind of like national number for you or national percentage, but I know that everyone is working really, really hard to, identify positives across the board and to get them in as soon as possible. And we're really, really looking for a 24-hour, no more than 48-hour turnaround, because we know that that is a very integral time when someone learns about their diagnosis and getting them on care. And the success rate of getting someone on antivirals as soon as possible is super, super important.
Thank you. Any other question? Well, there seems there's no more questions. Lisette, thank you so very much for helping us with this webinar, presenting this information. And thank you always for your support with Latino Commission on AIDS.
Oh, it was my pleasure. Thank you so much. And I look forward to future collaboration.
Thank you. And thank you, everybody, for joining us this afternoon to the webinar. Don't forget, our next webinar is May 23rd. It's about Latinos and hepatitis, where we are and what we need to do. The presenter will be Diana Padilla from NDRI. Thank you, everybody, and see you next time.